Yeah. Uh, Good morning, everybody. I think Dr. Tendulkar was very right in his Kovadi lecture yesterday, that in our generation you joined KEM because there was plenty of work. In this generation you don't join KEM because there's plenty of work. So, the topic that's been assigned to me is defining the boundaries of biventricular repair, a reality check. And I'd like to thank Dr. Bhupesh and Dr. Gaurav for the honor of participating in this CME. The topic, I think, is a question not just of science, but probably of philosophy. And why do I say that? Because when dealing with complex congenital heart disease, very often the dilemma for a surgeon is deciding between a low-risk operation, which has probably a poor long-term prognosis, versus a riskier procedure with a supposedly longer long-term survival. And this question is not new. It's been sort of debated for more than 2 decades. And these couple of publications show the earlier one way back in 1996 is a high-risk biventricular repair always preferable to conversion to a single ventricle repair. This was during the early days of the single ventricle repair. And then more recently, questioning as to how far we should push the envelope of congenital cardiac surgery. As congenital heart surgeons, we are sort of almost hardwired into trying to bring every patient to this so-called normal biventricular circulation, where we have 2 ventricles pumping into the 2 different circuits, the systemic and the pulmonary artery circuit. And when you actually look at what exactly is a normal, healthy biventricular heart, we need to fit all these criteria. And as congenital cardiac surgeons, we try to push every patient into finally achieving all these criteria, having atrioventricular and ventricular arterial concordance with normally functioning inflow and outflow valves, and more importantly, having both systolic as well as diastolic normal functions. Last is important, that these hearts, because you're operating at a young age, should have an ability to maintain normal growth and function as they grow. And this is a sort of target end result for all repairs for congenital heart disease. That's the aim. And so in trying to achieve this, we do not always achieve the end result. And in many situations, these are the sort of end results that we would have with the repairs that we do. Ideal, of course, is a biventricular heart with the left ventricle as systemic ventricle. The next option is to have a biventricular heart with the right ventricle as systemic ventricle. Failing that, we may achieve a 1.5 ventricle repair with the left ventricle as a systemic ventricle, or alternatively with the right ventricle as systemic ventricle. And then the sort of less favored is a univentricular pathway, achieving a Fontan circulation. And of course, the worst subgroup is where we cannot achieve any form of repair, and we leave them with some sort of a definitive palliation, which may be a systemic pulmonary shunt or a pulmonary shunt or a pulmonary artery band. And if you look at the long-term survival, as you go down this pathway, the long-term survival for these patients keeps declining, the worst being, as I said, the ones which do not have a repair at all. And this also fits in with the sort of hazard ratio for mortality in these subgroup of patients. If you look at this chart, the best patients are the ones who have a good biventricular repair, like the simple ASDs and ventricular septal defects. And down the line, the patients with the Fontan circulation have a hazard ratio of 20 times that of the normal population. And also, if you look at some of the end-stage treatment modalities like heart transplantation, which many of these would end up with, if you look at patients who have a biventricular heart with a left ventricular systemic ventricle, they have the potential for the best survival and the least complications following a heart transplant, vis-a-vis patients who have a single ventricle situation, where the hazard ratio for survival after a heart transplant is again much high. So again, going to indicate that as far as possible, the ideal situation, even if you have to have a late failure, is to have a patient with a left ventricle as a systemic ventricle. And so over course of time, although the Fontan circulation, the Fontan operation has improved considerably in terms of survival and late complications, but the perceived dismal late deterioration of the Fontan circulation, it pushes surgeons into trying to achieve a biventricular heart with preferably a left ventricle, despite the technical challenges and the multiple operations that may be involved. And this really is the question of testing the limits of the biventricular repair. And this didn't start recently. It started way back with the advent of the arterial switch operation, when initially the atrial switch operation sort of became well established as a treatment for transposition, but it left the right ventricle as a systemic ventricle, and then the push towards the anatomical switch, so that the physiological repair was thrown out of the books and the anatomical arterial switch became the gold standard. And this extended then on to patients with corrected transposition, ventricular septal defect, and pulmonary stenosis, where the Fontan was a much simpler operation with very low early risk, vis-a-vis the complex double switch, including intracardiac routing of the left ventricle to the aorta, doing atrial switch, and then an extracardiac conduit from the RV to PA, a much more complicated operation, but it very soon picked up and pushed the Fontan out of the treatment pathway for this condition. But then all patients are suitable for a biventricular repair, and there are many hurdles to trying to achieve a straightforward biventricular repair. The ventricles may be hypoplastic or borderline in function. The ventriculo-arterial connections may be discordant, and the VSD may be remote, precluding a direct connection. There may be straddling atrioventricular valves. There can be complex venous connections like in heterotaxy syndromes, and also a common AV valve with unbalanced ventricles. And these are situations where biventricular repair may not be achievable, at least in one stage. And therefore, here is a question of a choice between a complex biventricular repair vis-a-vis a univentricular pathway. But on the other hand, also, not every patient is a candidate for a univentricular pathway, because we all know that for a Fontan procedure, we need to meet certain criteria. So let us look at the situations where there is a left ventricle, but it is not adequate to do a primary biventricular repair. And this may be a regressed left ventricle, which is anatomically normal, but functionally not normal, like in case of a late transposition. You can have a borderline left ventricular hypoplasia, which is common in patients with critical aortic stenosis or hypoplastic left heart syndrome, or in a situation unbalanced AVSD. Or lastly, where there is extremely severe left ventricular hypoplasia associated with mitral atresia, and these are situations where biventricular repair is an absolute no-no, and these patients have no choice but to go down a univentricular pathway. So in solution is somewhat relatively simpler in a normal LV which is regressed, as in a transposition with intact ventricular septum presenting late. And in this situation, time immemorial, this has been a pathway where the left ventricle is prepared prior to doing an arterial switch operation, or it can be prepared after doing an arterial switch operation with the use of mechanical support. And this was published way back in 1989 by the Boston Children's Group. And from our own institution, we had also published our initial experience showing the effect of or the value of serial echocardiography in channeling these patients down this pathway of retraining the left ventricle rapidly and performing an arterial switch. And we were very happy that we could convert these patients into a successful biventricular repair with left ventricle as a systemic ventricle. But lo and behold, was this the ideal operation? 20 years down the line, some of these patients now have a left ventricle which looks like this. So obviously something which we thought theoretically was an ideal procedure down the line proves not to be so ideal. When you look at hypoplastic left ventricles associated with critical aortic stenosis, again the choice whether to do a primary biventricular repair, or are these patients going to fail a biventricular repair? And there are many, many echocardiographic criteria which have evolved over course of time to try and predict the survival chances following a primary biventricular repair in patients with critical aortic stenosis with a borderline left ventricle. Needless to say that in the long term, many of these so-called successful biventricular repairs also end up in late left ventricular failure. And this has been extended even to fetal life, to try and predict in the fetus as to see which left ventricle might go down the pathway of a univentricular heart and which will go into a biventricular heart. And then went on to trying to convert these patients from a univentricular to a biventricular heart by trying to do a fetal aortic balloon valvotomy. And this is one of the initial procedures, which is now slowly gaining ground, so that some of these patients who might intrauterine progress to a hypoplastic left heart syndrome might actually improve their left ventricles and achieve a biventricular repair postnatally. And then for the last challenge remains in patients with hypoplastic left heart syndrome. Traditionally, the Norwood procedure going down on to a Fontan palliation has been the established mode of treatment for these patients, and with time, the results with this have substantially improved, and many patients lead a fairly reasonably good life in Fontan palliation. But then now there's a push towards trying to recruit some of these left ventricles and trying to convert these patients through a complex series of operations into a biventricular heart. And this is again spearheaded by the Boston group. And you can see that the procedures involved in trying to recruit these left ventricles are quite substantial. You need to do a complex aortic valve commissurotomy and repair, a complex mitral valve repair, and then many of these patients have significant endocardial fibroelastosis, so an extensive procedure to remove this fibroelastic endocardium through multiple stages of procedures in trying to recruit these left ventricles. But at the end of all these procedures, not all of them succeed. Third of these patients actually progress to a biventricular repair, and through their studies, they have managed to realize that unless you achieve a left ventricular end diastolic volume of more than 30 ml per meter squared, or if end of these staging procedures you end up with an LVEDP of more than 13, then these patients will fail a biventricular repair. So situations where a patient would have done fairly well with a straightforward univentricular repair, at the end of all these complex procedures, you have a patient who has significant pulmonary hypertension or a patient who does not survive the surgery. Yet again, another push. If you can't maintain that left ventricle as a systemic ventricle, let's use the right ventricle as a systemic ventricle. So 20 years ago, the Senning procedure was damned because you left the right ventricle as a systemic ventricle. But now you're quite happy to do a complex operation because these patients have unseptatable hearts. You do a biventricular repair having the right ventricle as a systemic ventricle. So in this complex situation, this is the procedure that has been described. It's the patient with a heterotaxy, unbalanced AV canal with a hypoplastic left ventricle and a TAPVC. So the procedure involves repair of the TAPVC, intracardiac baffling, doing a ventricular septation, and then finally a left ventricle to a pulmonary artery conduit. The question is, how are these patients going to do further down the line? Yet another condition, transposition ventricular septal defect with a left ventricular outflow tract, who are fairly good candidates for a single ventricle palliation, but then we have these multiple complex procedures involving root translocations, a double root translocation, moving the pulmonary root backward, the aortic root backward to the left ventricular outflow tract, or doing a complete half-turned truncal switch operation in which you take off the entire aorta and pulmonary artery block, rotate it 180 degrees and reimplant it. Extremely challenging and complex procedures, all aimed at trying to achieve a biventricular repair, but with absolutely no information available as of today as to how they are going to do in the long term. And what happens when these repairs start failing? You juggle between one system to the other system. So if a systemic left ventricle starts failing, you try and convert it into a systemic right ventricle. If a Fontan starts failing, you try and convert it back to a systemic left ventricle, ultimately trying to avoid this final common pathway that all these patients ultimately, when they fail, they become candidates only for a heart or a heart-lung transplantation. And this again then is a question of testing the limits of biventricular repair. So we knew in the beginning that patients who had a senning operation and started failing, that they could be converted back into an arterial switch by retraining the left ventricle. And this was described initially by my mentor, Roger Mee, and initial series of patients. But not all of these patients could be successfully converted into an arterial switch operation. Yet another more coming now is the switchback operation. So a patient with an arterial switch operation has a failing aortic valve, which was initially the pulmonary valve, and then you go back and you take out that pulmonary valve and put it back in the aortic position, doing a so-called switchback operation. Patients with an unbalanced AV canal who have been pushed down the single ventricle pathway, then again these patients are picked up, and if the left ventricle seems sort of recruitable, then this again is the Boston children experience, that they can be reconverted back into a biventricular circulation. And then now people are talking about what are the considerations for biventricular conversion of the Fontan circulation. Should it be done electively or only for a failing Fontan? And then what is the feasibility? But then again, we have to come back to the same question, that we are doing all this because we perceive that the Fontan circulation is a bad circulation, that eventually all these patients will fail. So we must try and achieve, no matter what happens or how complex the procedure, try and achieve a biventricular repair. But then even in a condition like corrected transposition, where we know that the Fontan is technically a simpler procedure as compared to the other complex biventricular procedures, the long-term survival has shown that the patients who have had a Fontan circulation in this subset have the best survival, not just in terms of survival, but also in terms of preservation of the ventricular function. So 20 years down the line, whatever theories we proposed 20 years back, with follow-up, we are sort of being shown that this is probably not the right track to follow. And this is just a simple case which was a commentary by Baluddin, who commented on the paper from Boston Children's where they were aggressively trying to convert biventricle. And this was just a case report to show how these children can really suffer during this process. And this is, I'll read this out, because the child was born with borderline left ventricle, mitral and aortic valves. He underwent first stage palliation followed by a Glenn. Before the Fontan, he was considered for a biventricular conversion. Subsequently, he underwent 3 operations towards achieving this goal. These entailed atrial septal defect closure, takedown of the DKS septal myectomy, resection of the endocardial fibroelastosis, aortic commissurotomy, ascending aorta patch, mitral valve repair followed by replacement, pulmonary artery patch, and takedown of the Glenn with a superior vena cava patch. Although the size of the left-sided structures at that point seemed adequate and systolic function was normal, his recovery was prolonged and complicated. Invasive and non-invasive studies demonstrated significant diastolic dysfunction and pulmonary hypertension that improved over a few months, allowing hospital discharge. Nevertheless, he was readmitted 2 months later with heart failure and diastolic dysfunction. Despite the challenges of mechanical support in patients with diastolic dysfunction, he had left and right ventricular assist device implantation due to evolving end organ failure. While clinically improved, his transplant waiting time was long due to sensitization, and he developed embolic complications and subsequently died. So the question is aggressively pursuing biventricular repair always the right pathway? So my take-home message is that when dealing with complex congenital heart disease, the dilemma for the surgeon, as I mentioned, is deciding between a low-risk operation with poor long-term prognosis and a riskier operation with better long-term prognosis, within quotes. In many situations, what seems theoretically better turns out not to be so, as we have more long-term follow-up data. And while restoring anatomy is desirable, one must remember that physiology does not always follow anatomy, and probably a shorter life of a better quality may be better than an attempted longer life with poor quality. Thank you very much.